Yes, let me ask the four fellows who are going to present to come join me on the podium. Uh, I'm Mike McClung from Portland, and for the last 15 years, I've had the great opportunity to direct the Fellows Program, the Santa Fe Fellows Workshop. And again, we had a wonderful experience this year. One of the highlights of that conference is that we invite the attendees to submit abstracts. And 16 abstracts were presented. We present to each other at the Fellows meeting. The quality of the abstracts and the cases and the presentations was spectacular and demonstrated the breadth of different clinical issues that we as metabolic bone disease clinicians see. But it also highlighted the skill and the hard work that the fellows put into making those presentations. Dr. Belazekian and I review those 16 abstracts when we receive them, and we choose 4 to be presented at this meeting with the gracious consent of Dr. Lewicki. And we chose the ones to be presented here that we thought would have the most relevance for this clinical audience. And so not that these are necessarily better than the 12 that weren't presented. All of the abstracts were extraordinarily well done. So we have 4 presentations for different issues. And let me then, I'll introduce them one at a time. The first presentation will be by Tiffany Liu about a patient with juvenile Paget's disease. Tiffany?
All right, good morning, everyone. I'm Tiffany. I'm a second-year endocrinology fellow at Montefiore Medical Center in the Bronx. Today, I'm going to be talking about a case of juvenile Paget's disease. So I have no financial disclosures, and we can just get started with our case. This was a 24-year-old female with juvenile Paget's disease who was referred to our adult endocrinology clinic as part of her transition from pediatrics to adult. She had an unremarkable neonatal and early childhood course. She was 50 to 75 percentile on her growth chart in terms of height. And then she came into medical attention at age 2 when she fell while playing tag with her sister and then fractured her left femur. And then at age 4, when she started having premature loss of teeth, and between the ages of 5 and 6, she had multiple fractures, including her left clavicle and her left humerus. She would report pain while she was walking short distances and also when she was carrying things like her backpack. And additionally, at age 6, she was diagnosed with hearing impairment and started wearing hearing aids. Finally, at age 7, she went to Shriners Hospital in St. Louis for further evaluation. So while she was at Shriners, she underwent genetic testing and was noted to have a homozygous Iberian mutation in the TNFRSF11B gene, confirming this diagnosis of juvenile Paget's disease. Skeletal surveys done during that time demonstrated expanded osteoporotic bones, and her serum alkaline phosphatase was 1,500 to 2,000 in that range. Now, we're all very familiar with adult Paget's disease. It's one of the most prevalent disorders of bone remodeling and is second only to osteoporosis. It's polyostotic or monostotic and affects older populations, typically greater than 55 years old, and has a prevalence of 1.5 to 8.3% worldwide. Patients often achieve remission after treatment with bisphosphonates, and genetic factors are believed to play a role in about 15 to 40%, where individuals with clear genetic variants have mutations in the SQSTM1 gene on chromosome 5, which has been detected in both familial and sporadic cases. On the other hand, juvenile Paget's disease is exceptionally rare. It's got a prevalence of estimated less than 1 in 10 million and is diagnosed in infancy. It's associated with homozygous mutations in the TNFRSF11B gene on chromosome 8. And the reason why this gene is so important is because it encodes for osteoprotegerin. And for that very reason, juvenile Paget's disease is also known as osteoprotegerin deficiency. So in normal bone resorption, it's activated by rank ligand binding to rank on osteoclast precursors during osteoclastogenesis. Osteoprotegerin is a glycoprotein that regulates bone resorption by inhibition of rank ligand. And
Yep, there you go.
okay, it regulates bone resorption through inhibition of rank ligand by acting as a decoy receptor, and in doing so, helping to regulate osteoclastogenesis and bone resorption. In juvenile Paget's disease, the gene is mutated and the osteoprotegerin that's produced is unable to block that interaction, and thus these patients have just completely unregulated bone resorption and like disordered bone formation. It's a disease that presents early on in childhood, and often the initial presentation is with gross motor development delays and debilitating fractures. This is actually a photo of our patient at age 7 when she first presented to Shriners. She has a broadened forehead from skull expansion and a pretty prominent leg length discrepancy, as well as scoliosis. The chest X-ray is from age 13, where you can see bony dysplasia of her clavicles and deformity of her humeral heads. And then her lower extremity X-rays are from age 11, where you can see bowing of her tibia, as well as cortical thickening in both the tibia and the fibula. So how is this diagnosed? The initial step is based on serum alkaline phosphatase, which in some cases can be elevated up to 20 times. In our case, it was in the 1,500 to 2,000 range. Additionally, imaging studies such as plain radiographs are performed to show many classic findings, including the expansion of long bones. Bone scintigraphy is also done, and it'll show extensive uptake consistent with polyostotic disease. The bone scan that you see on the screen is from our patient at age 22, where she has increased uptake in all of her long bones and her skull. So how do we treat this? So the guidelines for treatment of adults with Paget's disease are very well established. And even though it is a separate entity, these guidelines are what form the benchmark for juvenile Paget's therapy. Due to the rarity of the cases, case reports and case series are really what form the foundation of published literature that is available. And various medications have been used with success in hopes of regulating the bone remodeling and inhibiting the osteoclastogenesis that we see. In traditional Paget's disease, bisphosphonates are the first line in therapy, and their success is carried over in the treatment of juvenile Paget's disease. Additionally, denosumab has been trialed with favorable results since its mechanism as a rank ligand inhibitor serves as a surrogate in the absence of osteoprotegerin, but unlike in adults with Paget's disease, these patients often will require lifelong therapy as disease reactivation occurs once the medication is stopped. And I'll kind of demonstrate that a little bit in my next few slides. So after our patient was diagnosed, she was started on alendronate, and this resulted in the normalization of her serum alk phos and the downtrending of her C-telepeptide levels. At age 15, she underwent bilateral femoral osteotomies with leg length correction, but otherwise didn't require any other surgeries or have any further fractures. Then she needed extensive dental work and tooth extractions. So the decision was made to hold the alendronate in anticipation. And ultimately, this period lasted about 2 years for one reason or another. And initially, her bone turnover markers remained relatively stable, but then by the time she came to see us for her first visit in clinic to establish care in the adult world, those values had risen quite significantly. Thankfully, she didn't have any fractures during that time. But then what happened next? So as soon as we saw her, we restarted the alendronate, which kind of leads us to where we are present day. She's been on it for about a year, and we are continuing to monitor her disease course and her progression on the alendronate. So in conclusion, her case really just highlights the presentation and expected treatment outcomes seen in this patient population. Juvenile Paget's is typically caused by genetic mutations resulting in osteoprotegerin deficiency, and children with delayed motor development and other clinical findings that are suspicious for juvenile Paget's should undergo further evaluation. This population requires lifelong therapy, and because of the recurrence once the medication is discontinued. And because of that, close monitoring really needs to be done to monitor for long-term side effects that may occur from treatment. So before I get to questions, I just wanted to thank everybody who helped me in putting this presentation together. Dr. Tabatabi, who is my clinical director and also the director of our program's fracture liaison service, Dr. McClung, who helped me review my slides. And also very importantly, Dr. Gottesman and Dr. Michael White from Shriners Hospital, who were so kind to discuss her case with me over the phone prior to my presentation.
Questions or comments, please? While they're thinking, Tiffany, this is a generalized disorder with the absence of OPG. Why are lesions, why are focal lesions seen rather than the whole skeleton being involved? So rank ligands made everywhere, of course.
So I think when I was reading up on this, So when I was reading up on this, I think there's a lot of discussion in the bone world between environmental factors and genetic factors in the development of Paget's disease. And one of the articles or some of the papers that I came across basically said that it could be because the genetic predisposition will result in affected cells, and then an environmental insult is what will result in the Pagetic lesions forming.
Good. Dr. Collins.
Hi, Mike Collins from Bethesda, Maryland. That was a great case and a wonderful presentation. Thank you. I thought I heard you say that she had developmental delay as well, and that was a feature of this disease. And what can you tell us about that?
So I said that she had developmental delays in terms of gross motor skills.
Okay.
Yes.
But gross motor skills because of the pain and fractures and that
Yes.
sort of thing. Okay, very good.
So-
'Cause her mind was
Her mind was fine.
Very good.
She's in college actually for graphic design. But she typically there are very rare, but these patients tend to have a lot of difficulties meeting their developmental milestones in terms of like crawling, standing, of that nature.
Thank you.
One more question, Paul, very briefly, just so we can keep on time.
Okay, Paul Miller from Denver. Nice presentation. These in adults with Paget's, you can see on scanning the EM, you can see viral particles, electron micrograph. Do you see viral particles in juvenile Paget's?
So there are osteoclastic inclusions in patients with Paget's and has been thought to be viral inclusion particles. Do we see those in patients, in osteoclasts in patients with juvenile Paget's? I have no idea.
Yeah. So I'm gonna kind of
Fine.
mirror that. where
Great.
I don't have any idea, but I think because it's genetic, you wouldn't really expect as much of like an environmental factor to play into effect. So I would go with my gut and say no.
Okay.
But
Thank you very much, Tiffany. The next presenter is Dr. Jordan Ross from the University of Tennessee Health Science Center. Jordan.
Good morning, everyone. Thank you for the chance to talk for a few minutes about a patient I've been following for a few years now since residency with my mentor, Dr. D.S. Thomas, who's had him since he was a little child. This is a 17-year-old young man with APESED, and this is his response to teriparatide and some of the persistent complications of his metabolic bone disease. So he only recently had confirmatory testing at the NIH. So his 2 mutations in AIR confer loss of tolerance to self. And so all of the autoimmune endocrinopathies that he has are due to loss of that tolerance. And so we'll only talk about hypopara today, but I'm going to give the complete list. So when he was 4, he presented with hypocalcemia, hyperphosphatemia, undetectable PTH, and that's what we'll talk about for the next few minutes. This is treatment course. But for completion, he has autoimmune hypothyroidism, and a year after that failed his cosentropin stem and has been on hydrocortisone, fludrocortisone. I put these in here partly to show how high of a dose he requires because of the malabsorption that's associated with this condition and the teenage missed doses that He has. He has hypogonadotropic hypogonadism, not primary the way orchitis can be seen in these patients. He's on androgel. He didn't like the injections. And I mentioned that because of his bones. Of course, he needs adequate sex hormone exposure for his bones. One slide back, I think. And then lastly, he has type 1 diabetes, multiple positive autoantibodies to the islets, stage 2, based on his OGTT last year. And so he was able to go to Vanderbilt in December and get teplizumab infusions, and he's remained off of insulin, which we're very thankful for. Here's his height and weight chart, not a mid-parental height because he's adopted Northern European ancestry. But you see he's been falling off of the height curve his whole life, delayed bone age. Those are the triangles attached to some of the heights. And as far as weight, he's always been underweight, but lost a significant after his 16th birthday. So in conjunction with GI, we referred him to surgery for a G-tube. He had a biochemical workup for celiac and inflammatory bowel disease, but the family elected not to undergo endoscopy, just do a trial of extra nutrition to see if that overcame some of the malabsorption. He has been on growth hormone in the past. Partly, I think part of his low IGF-1 is due to chronic underweight status. We're looking into weekly growth hormone, which is he prefers, but we'll probably have to do a stem test, which he's not as excited about. But again, we know growth hormone is important for bone health as well. So as far as the medical management, he's been on calcium and calcitriol up until 2 years ago. And again, you see the high doses of calcium and calcitriol required. His rate of hospitalization kind of accelerated over time. And during this time, the beginning of my fellowship, my mentor had already been thinking about teriparatide, and we worked with Dr. Karen Weiner to get that approved. And so that last hospital stay, he was getting admitted for IV calcium, and we had them bring the Forteo pens with them so we could start it in the hospital, initially twice a day and now 3 times a day injections. And remember his dose, it's 1.8 mics per kg. We'll look at the end at cohorts from the NIH and you'll see how high that dose is. He was able to stop calcium and calcitriol when we started Forteo, but he continues on cholecalciferol and magnesium. For my next patient with APESED, I think I would start getting bone turnover markers before starting Forteo, but since starting Forteo, we have them. And so, of course, we see how high the markers of formation and resorption are, which we would attribute to PTH exposure that he hadn't had for all those years. DEXA, again, we've only been getting recently. The Z-score for lumbar spine is negative 2.2. And then for total body less head, which we use for children with per ISCD, corrected for height is still surprisingly low at negative 2.3. Again, growth hormone deficiency, hypogonadism, chronic malnutrition, multiple factors. He has nephrocalcinosis. So here's a remote ultrasound and a more recent one showing the parenchymal deposits. And then he follows with nephrology for stage 2 CKD. So when we think about metabolic bone disease and APESED, the majority of these patients have hypoparathyroidism, but it's complicated by the malabsorption that so many of these children have. There's multiple factors. Some people, there's an element of just autoimmune impact on the gut, but there are many factors. And so these supplements that we've been providing him for all these years had to be at such high doses to overcome that malabsorption. These patients' bone mineral density tends to be relatively high due to low PTH exposure. But of course, that's not necessarily healthy bone, just dense bone. And even more surprising how low his bone density is. So we'll see how it changes on PTH therapy. So conventional therapy, of course, is the standard at the moment to initiate for all patients with hypopara of any variety. But the most recent hypopara guidelines have us consider teriparatide or PTH analogs for any of these issues. He's had most of them, even on a low phos diet before teriparatide. His phos was in the 8 to 9 milligram per deciliter. And the reference range is higher for kids, but that's still quite high. Lab draws at least once a week, hospital stays. So since starting teriparatide, he hasn't been hospitalized for hypocalcemia, His labs are now once a month. Most often, he's graduated high school. He works for a termite company, and he's so small, so he goes under the houses to look at the termites, which I think is probably legal in Mississippi. And so he, but there are randomized trials in these small groups of patients for teriparatide. Quality of life has good evidence of improvement until we have longer data on the bone and kidney outcomes. Lastly, I'll kind of end with our next step for him. We saw a few slides ago, his bone turnover is so high. And so what Dr. Weiner has had us do is add back a low dose of calcium and calcitriol to decrease his Forteo as we think about pump. And so this is a cohort with APESET and calcium sensing receptor mutations. And so the patients randomized to pump Forteo had a lower total daily dose, which is significantly cost effective for such an expensive medication. And even on that lower dose, maintained a higher calcium level near that goal of 8, the lower end of normal. And so for him, again, his dose is 1.8 mics per kg. So it's much, much higher than this cohort. And so this N of 1 compared to N of 12, still a small sample size, but we definitely have the opportunity to decrease that dose. He had labs this week. Calcium was 9.3, so we'll decrease Forteo today. I'll once again email Dr. Weiner and see what our next move is as we move towards pump for him. So any thoughts you'll have on PTH replacement for all of hypopara, thinking through this case with me, thank you all for the time to present him.
So that was a wonderful presentation of a very unfortunate person. And I tend to agree with you that it's the lack of IGF and the lack of some other essential elements that have prevented his bone really from acquiring a proper density. But I think one has to be very cognizant in selecting PTH for the treatment of hypoparathyroidism. When 1 to 84 PTH was first introduced, it was said, well, this will be a much better anabolic agent because it has a longer half-life. And it turns out that it wasn't a better anabolic agent, but it sure did help to promote maintenance, restoration or maintenance of blood calcium concentrations largely because of its longer circulation, concentration in plasma. So if the major issue that you want to deal with in treating people with hypoparathyroidism, frankly, being retired now, I don't even know if it's still available in this country. Mike is saying, no, 1 to 84 is not available in this country. Well, then this is just, a theoretical discussion. 1 to 84 in their clinical trials was much better in restoring calcium, even though it had trivial effects on BMD.
And I know there are new PTH analogs in the works. I think even there's word on TransCon just in a few weeks, which I only heard about.
But most of those are based on a smaller molecule, like 1 to 34, and that it's the kinetic issue that makes maintenance of calcium superior with the long molecule.
Right. Thank you.
Hi, Irene Stanchu. Very nice presentation. I'm concerned about his young age and using of PTH analogs, and I wanted to know your thoughts about that.
Right. So the NIH has most of the safety data for these cohorts, and they continue to do well on their pumps with teriparatide. And I think thinking about Dr. Bilzekian's reference of, the 2-year studies in a rat's life or 70 years in a human. But as far as surveillance for bony tumors and those sorts of things, there's no published data besides monitoring these kids as they continue on hormone replacement with the current formulation we have.
Great.
Thank you.
Jordan, thank you very much. I told you they were good, and they are, aren't they? So the next presentation would be by Varsho, who is from Allegheny Health Network, a very interesting case of a woman who had primary hyperparathyroidism during pregnancy.
Hello, everyone. I'm a second-year endocrinology fellow at Allegheny General Hospital, Pittsburgh. Thank you for this opportunity to share my case with everyone on this platform, and thank you for all the support from faculty that I've gotten so far. So I don't have a disclosures. My case is about it's case about the primary hyperparathyroidism diagnosed during pregnancy. So not a very tough case, but I think a couple of reminders that we can get from this. So 42 years old woman, she was a gravida 1. She presented at 33 weeks of gestation. She did not have any significant past history or medical or surgical. And she presented to obstetric department at our institution with symptoms of nausea and daily emesis. This was going on for at least several weeks. She had also some generalized weakness and fatigue going on and some palpitations. I think from going back to presentation from, I don't know if it was from hypercalcemia, that she was having palpitations as well. She was very thirsty, and on outpatient lab, she was found to have a calcium level of 13.2 milligrams per DL. She denied taking any calcium or vitamin D supplements. So other important thing about this case, I think going back that her OB history showed that antenatal ultrasound showed mild polyhydramnios. Something that's I think relevant to this case. Past medical and surgical history was not significant. She did mention to us about the history of papillary thyroid cancer in mother who had total thyroidectomy for that. But also important for us to know for these cases to find out about the family history of hypercalcemia, any family history of parathyroid disorders, renal disorders, or men's syndromes. And she did not have any. Social history was pretty unremarkable. She had medications, was only prenatal multivitamins. And also going back, the thiazide diuretics, other things that can cause hypercalcemia were negative in her case, are also contraindicated in pregnancy. Physical exam, unremarkable with blood pressure 131/71. I think her heart rate was tachycardic on arrival, which I could be related to hypercalcemia versus her dehydration state from hypercalcemia. She had no thyromegaly or no tenderness on the thyroid exam, no lymphadenopathy as well, normal heart rate and rhythm at the time we saw her, gravid uterus with otherwise unremarkable physical exam. And just want to highlight some things that if we get a case of hypercalcemia in pregnancy, we need to do a couple other workup, including the total albumin-bound calcium. So corrected calcium level was 13.4. In addition to that, we want to check the phosphorus level, magnesium level, which were low in her case, and also a PTH level, which was elevated to 215. She was also found to have a 25-hydroxyvitamin D on the lower side, not very low, but 26.8, a little lower than 30. And so in these cases also, it looks like she had primary hyperparathyroidism, explaining her hypercalcemia. A low vitamin D level could have caused secondary hyperpara, but not to this degree of hypercalcemia that we would have seen. And also, just want to highlight that 24-hour urine calcium and creatinine was also performed in the case. We wanted to make sure she did not have a familial hypocalciuric hypercalcemia, which can be seen in younger patients presenting with hypercalcemia. And so patient was admitted to inpatient and OB department, and we started with the workup for primary hyperpara and localization studies. She underwent thyroid ultrasound that showed that she had bilateral hypoechoic nodules on the posterior and inferior to the thyroid lobes, which were measuring 1.7 centimeters in size. These were suspicious for bilateral parathyroid adenomas. But interestingly, she was also found to have a hypoechoic nodule on her thyroid lobe, which was 1.6 centimeters in size, with well-defined margins and no calcification in the right lobe. So in terms of her management, we, since we don't have randomized controlled trials in these pregnant women with hyperpara, so we wanted to get a multidisciplinary team on board, including endocrine, ENT, OB team during her stay. And the recommendations was there was a consensus that patients should undergo parathyroidectomy. Concerning the level of hypercalcemia that she's had and to prevent the complications in maternal and neonatal. The most important thing also during these cases preoperatively was to make sure that we are doing the right thing. So FHH was ruled out, which should be considered in younger patients, which was in the pregnancy, sometimes we see absorptive hypercalciuria. but their urine calcium can be a little bit elevated. So there could be some difficulty in diagnosing FHH, but going back to their pre-pregnancy 24-hour urine calcium or post-pregnancy, which we are planning to do in her case, will help, or genetic testing can be considered. But I think her 24-hour urine calcium was grossly elevated. We also considered ruling out MN2 syndromes because of the thyroid nodule in her family history. And we had her adrenal MRI done during the hospital stay, which was negative, which was showing normal adrenal glands. She had a thyroid nodule FN as well that showed FLUS on the pathology. Now, one could argue we also considered pheochromocytoma, but did not send the metanephrine levels during her stay, just because of the time constraints of the test results. And the ball was really moving towards the surgery. So we considered just rule out with an MRI of the adrenal glands. She did undergo parathyroidectomy of 2 out of 4 glands. She had a 68% reduction of her PTH after first gland removal and 93% reduction after second. Right hemithyroidectomy was also performed simultaneously, concerning that her cytology was FLUS and we could not rule out MN2 syndromes. So she had hemithyroidectomy was performed. We were concerned about her being pregnant and her TSH goal to be around 2.5 in her pregnancy. We had started preemptively on her on levothyroxine and targeted TSH to be close to 2.5 when it was discontinued. So we can see at discharge, her labs kind of beautifully normalized. Her calcium level was 9.1 at discharge. Her PTH level normalized to 12. She was discharged on the calcium supplements and also vitamin D supplements, 1,000 units daily because of her pre-op vitamin D level on the lower side. And I just want to highlight that her pathology is also important to track. In her pathology, we did see just a hypercellular parathyroid gland with decreased stromal adipocytes. So you can see in the arrow pointing out towards parathyroid adenomas, and her thyroid biopsy was normal, benign. She had postoperatively pretty much resolution of all of her symptoms of nausea and vomiting. Her calcium and PTH levels remained normal throughout. And she did deliver with the C-section of a 3.5 kilograms baby at 39 weeks of gestation. And the baby was monitored in the NICU. Her calcium level of the baby was found to be around 1.2 millimoles, which was normal. So there was no neonatal hypocalcemia noted. So just going a little bit of the reminder for us to do things differently in pregnant women. On the left, I'm showing of calcium homeostasis in pregnancy, where PTH-RP is released by breast and placental tissue, which ultimately decreases the PTH production from parathyroid glands, and it causes calcium mobilization from the intestine, bones, and also excretion from the urine. But comparatively in the primary hyperparathyroidism during pregnancy, we see that the PTH secretion is significantly elevated, which causes decreased PTH-RP, but pretty much causes the degree of hypercalcemia is really significant, and hypercalciuria is really significant in these patients. So again, the recommendation by European Consensus Society is that every pregnant woman should be screened once with a CMP during their pregnancy so that we can pick up these cases early on. Concerning also because the complications of hypercalcemia are not related, are not just limited to maternal, but also neonatal. In the maternal week, we see hypercalcemic crisis, pancreatitis, hyperemesis gravidarum, which our patient was having. I think preeclampsia, which I think also because of the hypercalcemia causing increased sympathetic tone and palpitations. Preterm labor, I'm not sure, but I would think that hypercalcemia would have caused contraction of uterus as well. This is just my hypothesis. Polyhydramnios was also seen in a patient. I think the hypothesis behind that is that hypercalcemia in the baby is causing an osmotic polyuria of the fetus, resulting in polyhydramnios. And the most important thing is neonatal monitoring with PTH suppression can happen because of placental transfer of hypercalcemia in the baby, which can cause post-delivery neonatal hypocalcemia. So localization of hyperpara during pregnancy, we go back to our good old thyroid ultrasound. 4D CT is contraindicated, and systemic scan should be considered with a risk and benefit analysis with the patient to encourage decision about that. In our patient, it was diagnosed it was localized on the thyroid ultrasound. In younger patient, less than 40, just going back to asking family history and if there is any concerning for thyroid nodules, screening for MEN2 syndromes is also important. And minimally invasive parathyroidectomy is recommended in the second trimester if calcium level is 11.42 milligrams per DL or above. And mild cases can be monitored with the close monitoring of CMP during the pregnancy with a risk of with the monitoring of maternal hypercalcemic crisis also after the delivery. And the treatment modalities, we recommend surgery. We talked about conservative treatment. The calcitonin is recommended for a short-term treatment, and the cinacalcet and bisphosphonates can cross placenta, so they are not recommended during the pregnancy. So that was my presentation, and I think my.
Mike,
Thank you very much.
we have a remote question.
Okay.
We have a remote question, and that was calcitonin measured and should it have been?
Serum calcitonin measured?
So
Just for concern, but she had her thyroid out. This was just a remote question.
we measure the serum calcitonin on the patient, but I believe because of our pathology on the thyroid, surgery was benign. So, and I think we had also cytology before, which was also not concerning. So we did not go ahead and mention serum calcitonin. I would have thought about that if the scenario was a different, yeah, I don't think this was in our case.
Yes.
Hi, very good presentation, and you taught me a couple of things. Thank you. I just have two comments, which you might already be aware of, just for the fellows in the room. In addition to having a reduction in PTH of 50% intraoperatively, it needs to be reduced into the normal range. So that's very important. And then the second thing is there's a study that you also might be aware of to predict if somebody needs thyroid hormone replacement after hemithyroidectomy. If the TSH is above 2, more than likely they'll need thyroid hormone replacement. If it's less than 2, they're not likely to. And thanks for your presentation.
Thank you. I think we had the concern, and then we had started the patient on levothyroxine after the hemithyroidectomy, and then monitoring of her TSH after that seemed like she remained normal and was discontinued, and she remained euthyroid with TSH below 2 off the levothyroxine before the delivery. Thank you.
Thank you. We need help with the slides that are stuck and not showing here. No.
I have a question while we're waiting for our calcemic patient. Did he notice a difference in his mental health or, not that brain fog that our hypopara patients describe on PTH? And did he do a 24-hour urine? Two questions in one.
Yeah, so he definitely, again, we're from the South. He likes to hunt and fish, and his energy really improved. The trouble is sometimes his calcium will go up when he's having an adrenal flare. And so we stress dose hydrocortisone, his calcium comes back down below 8, but his energy improved. And then we tried a 24-hour urine in April. He didn't collect it completely. And his labs from this week just showed it was 1,000 cc's, and his urine was 79 milligrams calcium and 340 of creatinine. So it's that nice 0.2 ratio with an adequate weight-based sample. So I think he did it this time.
Good, thanks. And so our last presentation is Dr. Videsh Babu from the University of California at Davis. Videsh, welcome. Let's push those things to advance.
Thank you, Dr. McClung. Very excited to be here, as I am nervous. Thank you so much for your time. I won't keep you from lunch for too long. I'm Videsh Babu. I'm a second-year clinical fellow from the University of California, Davis, and I'm going to be talking about the off-label use of romosozumab on one of our patients with osteogenesis imperfecta type 3. I don't have any relevant disclosures yet. So as an introduction, osteogenesis imperfecta includes a group of genetic conditions that are involved with quantitative or qualitative defects in type 1 collagen, the most common ones being OI type 1, 3, and 4. Because of it involving collagen, fractures are a hallmark feature of this condition in addition to other findings. The incidence is around 1 in 10,000 to 20,000 live births. Bisphosphonates have been widely studied in this patient population. Randomized controlled trials have shown that there's an improvement in bone density. However, data is conflicting regarding fracture reduction. PTH analogs, specifically teriparatide, has been studied in a double-blind placebo-controlled trial. However, the effect seems to be limited to OI type 1. They did notice an improvement in bone density, but the study was not designed to look for fracture reduction. Data from denosumab is mainly limited to children and premenopausal women, and sclerostin inhibitors, it's pretty sparse, which is one of the reasons I'm presenting today. Quickly talking about our patient, she's a 63-year-old female with OI type 3 that was diagnosed at the age of 20 years. She did not have any similar family history or hearing issues or dental defects. She did have some graying of her sclera. She reached menopause at the age of 46 years of age, and she was placed on hormone replacement therapy for a duration of 5 years. She has been on PO as well as IV bisphosphonates during that time. Unfortunately, she continued to fracture despite use of both bisphosphonates. The last dose of her IV bisphosphonate was in September of 2019. Her fractures have included bilateral tibial fractures, bilateral fractures of her radius, ribs, vertebrae, as well as pelvis fractures. The last fracture was pelvic one in 2020. Secondary workup outside of the OI type 3 came back negative. And due to her continued fractures, we decided we needed to do something drastic. So we decided to start her on an osteoanabolic drug. In mouse models of OI, sclerostin inhibitors have been shown to improve the density, strength, as well as the osteoblastic apposition of long bones. We decided against PTH analogs at that time, specifically because of the study that I mentioned previously. So we started her on romosozumab for a duration of 12 months from July 2021 and transitioned her to denosumab. And I'm sure I'm going to get a lot of questions about that. The reason we picked denosumab is twofold. One, she's already demonstrated that she did fail bisphosphonate therapy, including IV bisphosphonates. And in some cases of PMO, it has been noted that Romo followed by denosumab has a more favorable profile than Romo followed by bisphosphonates. So let's talk about the pictures. Her bone density scan performed 2 years after Romo was started showed some pretty significant improvement in her LS spine of around 20%, as well as her total hip of around 16%. And I have the images here. These two are the last two. The most important thing is she also did not report any fractures since the therapy up to now. And she's been post-Romo for about 3 years. Quickly touching upon the discussion. So bisphosphonate therapy has been well studied in OI, especially type 1, but not so much in type 3. The reason we chose an osteoanabolic agent was because she continued to sustain fractures despite being on bisphosphonates. There is one case reported of a 65-year-old male with type 1 OI who was given romosozumab, and he had a pretty similar improvements in his bone density comparable to our patient. There is a phase 3 trial ongoing with setrusumab, which is another sclerostin inhibitor. And they're studying patients with OI type 1, 3, and 4. The phase 2 studies did show some promise. They're also looking at transforming growth factor beta neutralizing antibodies. And that showed some improvement as well in terms of bone density, but it seemed to be limited to OI type 4. So in conclusion, we would like to state that romosozumab may be used as off-label therapy for patients with OI type 3 who are not responding to bisphosphonates. I'd like to thank Dr. Mike McClung for your valuable suggestions and running through the PowerPoint with me. Dr. Sonal Phatak, who is Associate Prof at UC Davis, for identifying the case. Jen Quirkwood, who actually organized our fellows workshop prior to the Bone Symposium and got everything together for us, as well as the organizers. Thank you.
All right, thank you very much. Questions or comments?
Andrew Lancaster here in New Mexico. I'm an endocrinologist. What is your long-term roadmap for this individual, other than fly by the seat of one's pants? Yeah.
That is a great question, and I'm hoping we have more data by then to figure out what we can do next. I believe data from setrusumab should start coming out soon, so maybe that's an option down the line. But for now, because she has not fractured on the denosumab, we are going to continue it.
Other questions or thoughts? So this whole field of managing patients with osteogenesis imperfecta, a very different bone disease than osteoporosis, is still just blossoming. And now, as you say, we're awaiting the results of the clinical trial with anasclerostin therapy. So hopefully, when you guys have pushed us off the stage and come back to make the presentations at the Santa Fe Bone Symposium, we'll all be smarter about how to manage these patients. So thank you very much. So I thank the fellows who put in a great job of staying on time. We're on time. So let me turn it back over to for announcement about the lunch break.
Thank you. Thank you, Mike. Thank you, everybody. I think we got off to a great start. We're actually a little bit early. There was one question remotely for the last case, and that was, and you may have told us this, just remind us, how long had she already been on treatment with DMAP? And he asks, is in the pediatric age group below 20 who have been fracturing with bisphosphonates, is it safe?
I don't know the answer to the pediatric age group. I would defer that to Dr. McClung. With regards to the first question, I think she's received at least 6 doses or at least 5 doses of the DMAP, and she may be due for her 6th.
Good.
Great. I think we can. Waiting for the mic to start. Okay, I think we can stop. We'll go on to lunch. There's a session at 12:30, and we'll see you back at 1:30. Thank you all.
Great.